Hello, my name is Emily Reeve. I'm a pharmacist and researcher and one of the lead authors of the cholinesterase inhibitors and memantine deprescribing guidelines. This guideline is one of several evidence-based guidelines for deprescribing developed by the Bruyère Deprescribing research team in Ottawa, Canada. The recommendations in this guideline were approved by the National Health and Medical Research Council of Australia. Deprescribing refers to the planned and supervised process of dose reduction or stopping of medication that may be causing harm or no longer be providing benefit. Each guideline includes a 2-page algorithm to help clinicians make decisions about when to reduce or stop a medication and how to do so safely while managing other symptoms that may arise. This video shows how to use the cholinesterase inhibitor and memantine deprescribing algorithm. These medications are used to treat the symptoms of dementia. The algorithm has a front side with the step-by-step process for deprescribing and a back side with more information to help with the process. Our first case is Harvey, an 83-year-old man with Alzheimer's disease dementia living at home with his wife. Harvey was started on donepezil by his family doctor 4 years ago when he was first diagnosed with dementia. Starting at the top of the algorithm, we ask ourselves, why is Harvey taking a cholinesterase inhibitor? From his records, we know that it was started to treat Alzheimer's disease dementia. We also know that it was started more than 12 months ago. In speaking with Harvey and his wife, who is his primary caregiver, she mentions that she's not seen any benefit since he started treatment, and his memory has continued to decline at about the same rate, although she finds his care needs have really increased in the last several months. Thus, Harvey is a good candidate to recommend trial of deprescribing of his cholinesterase inhibitor. It is important to engage with Harvey and his wife to discuss their values and preferences and the potential benefits and risks of continuing or discontinuing the medication. The notes on the backside of the algorithm stress the importance of the conversation about deprescribing and provides additional information about things to ask and discuss. For example, discussing treatment goals, asking about their experience with the medication, both benefits and if they've experienced any side effects. They will also be informed that the medication can be restarted if necessary. After this discussion, both Harvey and his wife agree to trial deprescribing of his cholinesterase inhibitor. Because there is a chance that abruptly stopping the medication could cause withdrawal side effects, it is recommended to taper before stopping. Harvey is taking 10 milligrams of donepezil each day. This medication comes in 5 and 10 milligram strength tablets. We develop a plan to reduce his dose by half to 5 milligrams daily for 4 weeks, before then stopping it. We will monitor Harvey closely every 4 weeks for the first 3 months to check if he has had any worsening of cognition, changed behaviours or change in function. We can have Harvey and his wife visit the clinic, have a checkup via phone, or ask her to contact us if he is having any change in his symptoms. We will also make sure that Harvey and his wife know what to do if Harvey experiences worsening of cognition, changed behaviours or decline in function in between appointments. Months later, after tapering and stopping his donepezil, Harvey and his wife have noticed no change in his dementia symptoms or rate of progression, and Harvey is happy to be taking 1 less pill each day. Our last case is Deborah, a 93-year-old woman who lives in an assisted living retirement home complex. As we did with Harvey, we ask ourselves, why is Deborah taking a cholinesterase inhibitor? In this case, she's taking rivastigmine. Deborah was started on rivastigmine over 2 years ago for vascular dementia. Her family and the care team at the retirement home are unsure whether the medication has been of benefit and think that her dementia may have progressed faster over the past several months. She would not be classified as having severe or end-stage dementia at this time, but is dependent for most of her activities of daily living. Based on this information, we move to the next box. Over the past month or so, Deborah has often been refusing to take medications, including her rivastigmine, despite the efforts and encouragement by staff at the retirement home. She also seems to get agitated easily. As part of your discussion to determine her suitability for deprescribing, you learn that given Deborah's age and wish to focus on quality of life, Deborah's family are in support of her wanting to stop taking this medication, especially given the fact that the rivastigmine could be contributing to diarrhea that she's been experiencing for the past 2 years. She's also lost some weight over that period. Deborah would meet the criteria to recommend a deprescribing trial. Like our previous patient, we need to talk to Deborah and her family about deprescribing, explaining the rationale and process for deprescribing. Given that Deborah is on rivastigmine 6 mg daily, and it's available in 1.5, 3, 4.5 and 6 mg, it would be best to taper this medication. For example, lower her dose in half to 3 mg daily for 4 weeks, followed by 1.5 mg daily for 4 weeks before stopping. However, given her refusal of medications and the fact that she's only taken 2 doses in the past 2 weeks, it is decided to stop the medication now and monitor closely for any adverse drug withdrawal reactions. You plan to follow up Deborah within 1 week to monitor for withdrawal, and then every 4 weeks for the next 3 months. The retirement home staff and Deborah's family have also agreed to help monitor for any worsening of cognition, change in behaviour, or change in function, including her bowel motions. Fast forward, it has now been 3 months since Deborah stopped her rivastigmine. Her family and retirement home staff have not noticed any worsening in her cognition. They think that she might be less agitated than she was. Best of all, Deborah no longer needs to use loperamide for diarrhea and is happy to be on 2 less medications every day. Deborah still doesn't like taking her other medications, and her family ask if she still needs all of them. This gives you the opportunity to conduct or refer Deborah for a full medication review to see if she can have any more of her medications deprescribed. I hope you found these examples helpful to understand how to use the cholinesterase inhibitor and memantine deprescribing algorithm and to make decisions about when and how to reduce their use. Remember, the goal of deprescribing is to reduce medication burden and harm while maintaining or improving quality of life. It should always be done in partnership with the patient and their caregivers and with planning and supervision by a healthcare professional to make sure it's appropriate and safe. The Deprescribing Guidelines project was initially funded by the Government of Ontario through the Ontario Pharmacy Research Collaboration. The cholinesterase inhibitor and memantine deprescribing guideline development was funded by a National Health and Medical Research Council and Australia Research Council Dementia Research Development Fellowship. I'd like to thank our guideline development team members, as well as all those who contributed to developing and reviewing each of the deprescribing guidelines and algorithms included in this important initiative.